Okay, everybody, I just wanted to make sure that, Deb just shared with you the web pages or the links to some of the help desks. But on our data submission, the IRF data submission deadlines webpage, we have a lot of those resources also. And in addition, we also have the NHSN website information, but I'm going to give it to you just in case so you have it. So if you have any questions about your CDC data, nhsn@cdc.gov. So that's the website. Anyway, so we did have a couple more questions. In addition to the questions that, we had mentioned that we want to get back to you after we've had a chance to discuss with the other setting leads. But let's see. This one. Yeah, we had a question about, does a spinal cord injury patient have to perform their bowel program over a toilet? If they, glasses should be on. If they perform their bowel program in a bed as a scheduled event, should the nurse score them as continent or incontinent? And we believe they should be considered as continent since it is scheduled, assuming that it is a result of your program plan. Can we code toileting if they do their bowel program in a bed or a chucks? If we can't, is the correct code 88 versus not attempted due to medical condition or safety concerns? And our answer is no, they should be considered as continent since it is scheduled, assuming, again, that it's part of your program plan. Oh, we had a couple questions. We had the issues with the webcast and the streaming today. The videos from this training, as well as the training from Dallas, will be posted and publicly available, and we hope to have the Dallas videos posted very soon. But we will send listserv messages and email blasts out once they become available. A lot of you guys asked the same questions, so you're all thinking the same thing. We can do that one. Okay, we had a question. For walking in wheelchair, is there a standard flooring? It can be very different from a linoleum surface compared. Lost it. What was the rest of it? I lost it.
A carpet.
Oh, right.
Yeah. So it's not on a carpet. It's just in the hallway of a hospital. We have obviously the other item that speaks to uneven surfaces, which would pick up some of the other harder surfaces, but for just a regular wheelchair and a regular walking item, 10 feet, 50 feet with 2 turns, and 150 feet would just be regular flooring at the hospital.
We did have a question. UDS does not consider the curb of a sidewalk to be a step for the FIM score under stairs. It's coded as 0 on the FIM for stairs. Please confirm or clarify that the care tool item GG0170M does consider a step as either the curb of a sidewalk or a single platform step. And yes, that is correct. I think these were all. Yeah, I think that's pretty much it. Do any of you have any questions that we haven't touched on that we have mentioned that we need to get back, like the parallel bars, the rolling?
Hi, I'm Jeff Orange from Kindred Healthcare. I have a question. I'm wondering if you could speak to or clarify recommendations for best practice for assessing the functional items in the QRP, because throughout the last couple days, what I'm hearing is that we're supposed to get baseline performance before therapeutic intervention, and then we're also hearing that we're talking about usual performance, which to me implies that then that item's going to be scored several times throughout the stay. So, in to meet the guidelines, obviously for 3 hours, we're going to assess the patient, but we're already going to be starting on therapeutic and rehabilitative interventions, compensatory strategies, because for safety to improve their function. So can you speak to that for us?
Sure. So, I mean, doing these functional assessment items shouldn't be changing your practice in general. I know the BIMS might not be something that you currently do, and so that might be something that's new. But in terms of the GG items, so something like stairs, 12 stairs, might only be done at discharge. It's not feasible to do on admission. It's not safe for the patient, maybe even the therapist, nurses. And so that might only be done at discharge. And it may only be done, maybe once or twice during those last few days, like maybe not the day of discharge because somebody's leaving early in the morning. So maybe it happens the day before discharge. And, it's happened a few times, but it only happens once. So then, probably PT might be the one in that case doing that. For something like eating, where there's multiple opportunities to observe the person on admission and discharge, that's when those kinds of things become important to consider, what is generally happening, not just once in therapy, but so it's possible that maybe an OT might be assigned to kind of assess that item within a facility, but then the OT would want to definitely check with the nurses who are observing the patient in the, other circumstances when it's noisy and maybe, there might be different levels of assistance because the person can't concentrate and they've been taught in acute care that they're supposed to be doing a double swallow or something like that. So it kind of depends on the item. Toileting is another one that, people go to the bathroom all the time, so there's multiple opportunities to see that. That might be nursing, might be OT. That's going to be a facility decision in terms of who does that. But, bed mobility happens a lot, but car transfer probably mainly at discharge, maybe only once during the discharge. So hopefully that helps a little bit.
Hi, Samantha from Advocate Illinois Masonic. I just had a couple clarifying questions. I didn't catch the whole thing. What is the height of the step? I thought I heard that the height of the step didn't matter.
Nope.
So
That is correct.
We don't have a defined height.
don't have a defined height. And the other one is for upper body dressing. Well, no, bathing and showering, hair and back is not included, correct?
That is correct. Washing hair is not included in the bathing, and washing the back is not included in bathing. That's
Okay,
correct.
thank you.
Hi. This is just a clarification too. So when we're talking about the use of the dash, so it was saying the use of the dash for admission and discharge may result in a payment reduction. And then it says using the dash does not affect the APU determination. What is exactly the APU and what was the determination?
Loaded question. The APU, it's a payment.
Do you want me to?
Yeah, I was going to say, I don't even know
so,
how I want to say.
so in general, I guess we'll
Right.
start at the beginning just to be sure everybody's on the same page.
Right.
So as part of the IRF quality reporting program, CMS is asking you to submit data on the quality items. If you're not submitting the items, there is a special threshold. There's various things. We won't get into those details, but basically, if you're submitting, for the most part,
Right.
complete data on all of the Medicare patients on the IRF PI and the CDC data, the billing data comes in anyway for readmission measures. If you're submitting that, you're fine. If there is a lot of data that's not submitted, if there's data that's not submitted and you get past the threshold, you're at risk for a financial penalty related to your annual payment update. So that's what APU stands for.
Right, and you need to submit 95% of your
Quality item data.
quality assessment data and 100% of your NHSN.
Yeah, so there's more details on the website and definitely get more details.
Right.
But that's generally, and that's what APU stands for.
Hi, Marjorie Mantion, UDS. Just a couple of questions related to the medical record documentation components. Can you explain what the impact will be, if any, when physicians and the wound care specialists are documenting based on the new wound care standards versus those that support the IRF PI data requirements?
Right, I would imagine if they're documenting the presence of the pressure ulcer or a wound, that it's going to support whatever documentation you're adding to the IRF, because they're at least acknowledging the existence of the pressure ulcer. I mean, I'm not sure that that would impact, I mean, the guidelines, I mean, we follow the guidelines, but as we discussed earlier, when Ann presented earlier, they're not exactly parallel, but
Right.
we're using the same principles. So I'm not sure that it would have any impact. You're still not capturing that data.
Okay,
Yeah, I
and
think if you have a specific concern example,
Right,
maybe if you could write
right.
it down, and
Okay.
that would help
Right,
us.
right.
But, you know, something like calling something a pressure injury versus a pressure ulcer.
Right.
I mean,
Right.
it theoretically shouldn't
No, it shouldn't.
affect.
And then just secondly, what is the expectation for clinician documentation to be able to accurately represent the variabilities between the FIM and the quality measures? I mean, I know some EMRs are being reprogrammed, you know, they have current systems that have drop-down selections to support FIM measures. Now EMRs are being, you know, implemented and revised to be able to also support the quality measures. Is that sufficient, or do the therapists have to have, you know, additional documentation to support the various two measures?
I mean, from a general standpoint, I mean, if whatever you're documenting on the IRF should be supported somehow in some way in your documentation. It's in the medical
Right, but there's
record.
different qualifying factors for each measure. So, you know, therapists have been trained for many years to be documenting, you know, to support the FIM measures, but now they also have to document and make sure that they're supporting the quality measures. So I think a lot of facilities are struggling a little bit with how to best implement that with their staff.
So just maybe one example that I can think of. So, you know, if if a patient requires supervision, you would be documenting that. And so information can be derived, you know, when you're filling out the IRF based on supervision being required for eating. If somebody's on a G-tube, you know, you wouldn't necessarily, and they're not eating, that would be important information that maybe, you know, wasn't considered with eating, you know, with FIM. I think, you know, when I've looked at medical records and IRFs, maybe there needs to be more detail about like oral hygiene in particular. So, you know, that level of detail might not have been there before. So those are just some examples that come to mind. Does that help at all?
Okay, could we also submit like maybe
I was just
examples?
going to suggest that
absolutely,
any
absolutely.
suggestions, because we will post them and we'll continue to post questions as you guys are
Okay.
working to implement. We know after maybe once we implement this on October 1, you may come up with more questions. We'll continue to respond to the questions
Okay,
and post them.
thank you.
Thank you.
Hello, Jessica from RIC. I just want to clarify, will an IRF meet the CMS quality regulation if it implements the process to have one discipline rate a quality indicator one time? So, for example, OT is responsible for all of the ADLs and PT does the mobility, nursing does bowel and bladder. And we don't necessarily, the activities that are assessed by more than one discipline, we don't necessarily look at all of the discipline ratings, we just assign it to the one discipline.
I don't think we're dictating who completes the items or the sections, or if you decide you want OT, you know, coding or scoring based on what their assessments are. I don't think we're being that prescriptive. I think you have to look at the patient, though, and make sure you're addressing, you know, we're hoping you're looking at the patient to determine goals. And if that requires more than one goal, or you want to implement one goal to, I mean, you want to consider the needs of the patient. We don't want to say we limit you to identifying one goal. I mean, I think you need to consider the patient and what the needs of the patient are.
Okay, thank you.
So
Yeah, and-
if that helps, I don't know if I'm answering that for you or not, but we're not prescribing who does what portions.
Yeah, and I think in general, for most of the items, there would be more than one discipline involved. But like, I'm just thinking maybe car transfers might be one example where maybe a PT or an OT is working on that, and maybe nursing, you know, isn't involved, and so there truly is maybe only one discipline on that particular area. But in general, I mean, I think the expectation of interdisciplinary communication, all of that would be considered in scoring.
Okay. So, for example, I just want to be 100% clear. I'm sorry. For like oral hygiene, OT obviously assesses that, and nursing sees that too. And we run into situations often where nursing and OT do not score similarly. So, is the expectation here that we look at nursing and OT and come up with something that's correct, something that's one or the other?
Well, I don't know if it was Ann or Jen who earlier talked about that. If you have a discrepancy in what you're assessing with the patient, that would be interdisciplinary. I would hope that OT and nursing got together to kind of discuss what's going on with the patient, what the differences were and why, to come up with an agreeable response for their assessment when you